My name is Lynn and I'm studying to become a B.C.B.A. In this video, we're going to cover Unit 2 of a class called BEH 5041. And Unit 2 covers the assessment of social validity, treatment integrity, and risks. So this was a particularly interesting unit to me just because there was so much that goes into it, and a lot of it is actually rather subjective. So let's dive in. This unit covers social validity, which is basically the idea that we are covering socially valid behaviors, right? So if a kid is clapping a lot, we're not necessarily going to say, no, you have to stop clapping forever or anything like that. But if they're, let's say, hitting their head or exhibiting self-interest behaviors, we do want to intervene with those because socially speaking, those are very alarming to people who don't know what's going on, particularly with those types of behaviors. If you have a client who goes around and bites people, that's a socially valid behavior that we can intervene with. But if a kid likes to play with a fork or a spoon and they just like to tap it on themselves or just like play with the reflection, is that really a socially valid behavior that we need to intervene with? So that's what this whole unit talks about. So social validity is the degree to which the consumers find our involvement acceptable. You see what I mean by subjective? So we're discussing this from beginning to end. Do people find what we're doing acceptable in the context of what we're doing, of how we're doing it? So social invalidity in that respect would be socially expected outcomes are unmet. So you want to make sure that your actions and your interventions reflect trying to go towards an ultimate goal and that they make sense. That being said, there's a lot of subjectivity within social validity, right? So eating with your hands can be acceptable in one culture and not another. So you want to make sure that you're going after socially valid goals. The most common example of this being don't force a utensil eating goal if the family doesn't value eating with utensils and only eats with their hands or predominantly eats with their hands. So we want to make sure that we're respecting the diversity of the social expectation and social validity. Because of that, we can't really rely on subjective measures, but there are different ways we can measure social validity in a sense. So those areas would be in our goals. So what items are important to our client's life. Procedures, so what are acceptable methods? Do parents want to put punishment in? Is there a non-punishment goal that we have? Is praise acceptable? So those types of procedures. And results. Are the clients satisfied? Are the caretakers satisfied with how the results are showing? Like if you reduce head banging from 50 times a day to 20 times a day, yes, that's a notable change in rate, but is that ultimately going to help the client if they still end up with concussions or hurting themselves because they're only hitting themselves in the head 20 times a day, right? So you want to make sure that the results, both predicted and unpredicted, by the way, actually are what the caretakers and stakeholders want. From there, they talk about a study from Hanley 2010, and this one I thought was pretty interesting, and it's called Efficiency Without Adequate Social Acceptability is a Recipe for Marginalization. It's from Hanley 2010. That whole sentence of efficiency without adequate social acceptability is a recipe for marginalization is a big reason why ABA struggles to have a good reputation. So just bear that in mind, right? People have to approve of what we do before we can actually do it, regardless of if we have science to back our data or we have data to back our science. It needs to be acceptable, right? From there, it talks about how to make socially valid items by the identification of goals, which they did in Unit 1, which is basically broad social goals, so the ultimate outcomes, behavioral categories, which are intermediate outcomes, and then discrete responses, which is our short-term outcomes. And from there, we evaluate social validity within all of those. So first we have to consider who is evaluating. Is it the family? Is it the community at large, because you're going out to the community? Is it stakeholders? So not just the immediate family, but the teachers, the relatives that are in that person's life. Who's evaluating the social acceptedness of your intervention? Second is determine when to assess. So this is kind of the idea that you're taking information from like your pre and post interviews and pre and post assessments, because you're trying to make sure that when you select the goals that they make sense, right? Like we want to not only choose behaviors to affect correctly, but we also want to make sure that people are kind of in agreement that yes, we want you to work on that behavior, right? So it's just making sure that everyone else in the party, not just you and the client, are involved in the process. The third idea of evaluation within social validity of your items is identifying what to assess. So what are the measures of the goals? What is the importance of the goals? And what is the current performance compared to your ultimate outcome or your goals? So that's just making sure that you're measuring things correctly and using the right units of measure for that. The fourth item is select methods/tools correctly. So you'd want to use do you want to use a normative comparison, which would be like, how are you comparing them to others, like a standardization, kind of like an SAT or just standardized tests. So that's like a normative comparison versus an in vitro comparison. So how are they compared to themselves as opposed to like 6 or 8 months ago? That being said, you want to make sure that you're using, for normative comparisons, you want to make sure that you're using established criterion. There's pros and cons to each, of course, but you want to make sure you're using the correct tools when you do it. So like they bring up the example of the VB map for an established criterion for a normative assessment. Beyond that, you want to discuss how the severity of the behavior is affecting the person's life. So the severity of behavior is the response before treatment. So if there's no intervention, what is the level of behavior, right? So you can predict this by just observing. And then you can say like, okay, I saw that the client hit their heads 50 times on a wall one day, 40 times the next day, 45 times the next day. I can predict that they'll probably hit around between 40 and 50 the next day, right? So that is the severity of their problem, behavior, I should say. And what is the setting for the treatment and how are you going to generalize or restrict control, stimulus control, right? So because of that kind of idea of what severity of behavior is and how you're going to approach it, you need to consider the 4 steps of risk-benefit assessment. So we need to see how beneficial it is to intervene versus what is the risk of not intervening, right? And that is something that you measure first looking at the severity of the behavior. So the first step of the 4 steps is assess general risk factors of behavior for treatment. The second step is assess the benefits of behavior treatment. And then the third is assess risk per procedure. So every procedure has the risk and every procedure has their benefit. Whichever procedure you choose, assess the risks for that. And then the fourth is reconcile the risks and benefits for all parties involved. Now, the unit goes in much deeper into each step, but if I did that, would kind of be here all day. You have to remember I'm distilling like 8 hours of lecture into 20 minutes. Just recognize that you need to remember those 4 steps because they do ask you in the unit quiz about them. But basically, you're just making a pros and cons list, to put it simply, listing them down and then putting in the procedure, making a pros and cons list of that procedure, and then talking to all parties involved and saying, do you feel this is worth this risk if we do it? Do you feel this benefit is worth this risk, and so forth? So it is a subjective measure because of that, but the pros and cons in and of itself will depend on what's valued by the client. So those are the 4 steps of risk/benefit assessment. Now remember, risk is the nature of the behavior by sufficient personnel, training, setup, and so forth. And what is the client buy-in? So how are they, do they approve of your intervention and are they willing to follow your intervention? So that's kind of where risk lies. That's how they kind of defined what is the risk involved versus benefit. So what is the benefit involved for the client, the setting, the caregivers, and the peers? So that they discuss all those after the 4th step of the risk and benefit analysis. After that, they talk about the 3 levels of procedures. They go into length in all these procedures. I'm just going to cover a general breadth of them, but make sure that you study them when you get to this particular unit because each one does have a specific way to use them, and they do go in depth into each of them. But that being said, the first is a comprehensive treatment program. So you want to have a clear description of full programming. So there is, for instance, like what is the setting? How is the training? What is specific about it, right? So how are you tackling the specific items in there? What is the short-term goals within this? The second level of procedures is what are the components of the treatment program in and of itself? So they go into, what is the goal? What is the sequencing? What is the methodology of what you're using? What is the tool that you're using? And also, are you incorporating parent training? So parent training, just by the by on the side, should be incorporated in every step that you can, because you will not be there forever, but the parent of that client will be. So as long as they are there 24/7 with that client, then you want to make sure that they know how to do things as well as you do as it pertains to their child, if they agree to learn. So having that agreement to learn is a huge factor. There's even steps to take if parents refuse to participate. Now, this is not including like clinical places where like a parent brings them to a clinical place and then they leave them there and they do all these things. That's a separate issue. But if you're going one-on-one in a home and there are parents that agree to it, there are even some insurance companies and payers that I know that if the parents don't commit to actively participating, they can lose services for it. So that's a big deal, as you can imagine. So you want to make sure that parent training, if it's required through the payer, the insurance, or whatever, that it's included in every step of the way and that you take data on it. You want to make sure that you said, I asked mom if we could go for a walk to practice community goals today. Mom said yes, and we went out, or mom said no. And after enough times of that data, you can show the insurance company or payer, this is what's happening and this is the consistency of it. Right, so just keep that in mind. That's on the side. Anyways, going back to the levels of procedures, the third level of procedure is specific behavioral procedures. So this is the planned treatment component. This is when you train the BT or R.B.T to actually perform the intervention with this particular client, how you do it, what the expectation is, what a correct answer looks like, what an incorrect answer looks like, and what the resulting reinforcement should be or the consequence of their action should be. So as you can imagine, it's talking about the levels of procedures going down to the specificity of that procedure. And then from there, they talk about how do we know from nonverbal clients or clients that do not communicate fully, so to speak, with us, how do we know of their agreeance or their consent to our interventions? It's not just age, although age has a factor to it, but there's something that the co-instructor called Indices of Happiness, which I just love that phrase. But Indices of Happiness, which are actions and behaviors that are correlated with pleasant opinions or feelings. Very subjective, I know, but it's things like smiling, laughing, attempting to hug or give high fives, attempting to move towards that activity, item, or person who's connected or associated with that activity more frequently than less. That one is really utilizable to show a form of social validity and consent from the client themselves if they are nonverbal, so to speak, or are incapable of expressing immediately to us whether they want or enjoy doing something, right? So it's kind of like, how do we know they prefer something through a preference assessment? When they engage with something for a long period of time and they laugh and they giggle and they keep engaging and engaging, no one's going to assume that they don't like that item. It's an indice of happiness that they do like that item. So that's just where they take it from. The next topic that they discuss is the treatment integrity within performing the actual treatment. So is the treatment condition implemented as designed? Is your R.B.T or B.T actually doing what you taught them to and implementing the treatment in the correct manner? This is not to be confused with procedural fidelity, which is adherence to all conditions of research design. So like baseline and treatments. Procedural fidelity versus treatment integrity, they don't ask too much, or at least for my class they didn't, but they don't ask the differences between them, but they do mention it here and there within the test, I remember, where they say like this, they give you a scenario and then they say like this thing lacks treatment integrity, or it lacks social validity, or it lacks this. They didn't really compare it to procedural fidelity, but basically you just want to make sure that if the treatment integrity is high, that means that they're the BTs are performing it as you would expect, versus procedural fidelity is what is the overall treatment in comparison to what the research says, right? So that's how they separate it, is procedural fidelity is much less focused on your client versus treatment integrity, which is highly focused on your client. From there, they discuss 6 steps to assess treatment integrity. Again, this unit has a lot and all of them have steps. So the first step is select the treatment to measure, right? So what are you measuring? What method are you going to use for this treatment or intervention? Number 2 is to define the steps of the select treatment. So you want to make sure when you do this that you include examples of a correct answer, examples of an incorrect answer, examples of prompting levels, who can do it, where it occurs, things of that nature, because that will really narrow down the consistency of how reliable the measure is, right? Number 3 is determine the type of treatment integrity data. So how are you going to determine that it has integrity at all? So that is to say, are you going to use like a global score versus specified components or a criterion, so to speak? Like, what are you going to use as determining its integrity? So for this particular example, they used an experienced R.B.T versus an inexperienced implementer. So an experienced R.B.T, you can have them run an integrity check with a global score that's compared to a normative score, versus an inexperienced implementer or someone who's brand new, who's a BT, not yet registered. It would be best if they could analyze and assess specific components of a treatment so that they can focus in on one step versus an experienced person who can kind of grade all the steps. So that's part of the integrity data that they use. I'm sorry if that seems a little confusing. I promise they go into more detail in the videos and they spend a long time talking about it. So I just had to kind of narrow all that down. Step 4 is measure the implementation and record implementer behavior. So this is where you're watching the watcher and you're also making sure that they're implementing it correctly. So there's different levels of assessing overall treatment integrity, and that's making sure that you're watching the person who's implementing the procedure, but also measuring what they're trying to measure. So you're kind of doing a lot of things. There's a lot of plate spinning when it happens, but you should be able to, because you're the one who created the intervention. The 5th step is to compare data and compare the data to predetermined criteria. So what is your expectation? Should you guys be at like a 90% occurrence of inter-observer agreement, and do they need to perform the intervention at a 90% or higher score? So that's what you're comparing the data to, is that you've expressed the expected criterion and you're going to jump into it and compare whatever data you take to that criterion that you already decided on. And then the last step, step number 6, is to train the implementer accordingly. So if they reach that criterion, not much to be said, just give them positive feedback of like, hey, you did really well with that, you've reached the criterion, that's great. Otherwise, oh, like this, we're experiencing low treatment integrity, we're not really touching base with step 4 and 5, we got to do this, we got to do that, we got to change the task analysis or something like that. Just make sure that you're not making it so it's their fault. It's really just about understanding, okay, what in this environment can I help you succeed with? So if something's not working, that's where your treatment integrity assessment really matters, and you got to make sure that you can figure out how to fix it. After that, they talk about common types of errors within treatment integrity. So there are 2 types of main treatment integrity errors. There's omission and commission. Commission is far worse, but I'll describe what both of them are. An omission error is failing to implement a step as designed and failing to reinforce a correct behavior, right? So if a kid says, I want candy, and you don't give them candy, and so they resort to like smacking you, that's like, okay, that was on me because they did the correct action, I just didn't reinforce it. But a commission error is applying intervention when not indicated by the plan. So this one would be the kid asked you for candy, you did not give them the candy, so then they start pulling your hair and hitting you, and then you immediately give them the candy. You've just reinforced the wrong response. So that's basically what they're referring to by omission and commission. Omission is way more harmless than commission because you don't want to increase the incorrect behavior, right? You don't want the kid to pull your hair and hit you in order to get candy. You want them to request correctly. Those are the 2 main types of errors. They will ask you about what type of error occurred in the test. They ask quite a few. The last main part of Unit 2 discusses formal reassessment. So again, assessment is an ongoing process. So formal reassessment is periodic, comprehensive assessments to identify progress and reevaluate existing behavior programs and problem behaviors or behaviors you are trying to influence. Why do we do this? Well, we got to track client progress. A lot of times funding sources will require you to reassess. Usually it's in a 6-month stint. For some sources it's shorter, for some it's longer. Usually it's 6 months. It might be an organizational policy. So maybe your company says we need to reassess them every 6 weeks. That's very common. It might be just overall curriculum. Like if you're in a school case, the curriculum might require you to reassess. From that, they discuss the 3 levels of outcomes. This is a reoccurring theme, as you can see, but they have very specific names to them, which is really funny to me. But the 3 types of outcomes, for formal reassessments are proximal, which are short term, right? So what are the immediate results and measurable skills? And then intermediate results, which is nice because that's the name of the previous one listed as intermediate results, which is the larger category of the skill. And then the last one is distal. A distal outcome is the bigger picture. It's more of the whole point of the overall goal. It's the reason why your goal is doing it. That is the ultimate outcome that you're performing. So the way they discuss it is proximal is like being able to to sit down and do math problems. Intermediate is being able to perform well on a math test. And then distal is passing the math class, right? So again, just 3 levels of outcomes. You'll see that pop up again probably in the next unit. And then the last section of Unit 2 discusses assessing social validity of outcomes. So it's basically just describing how you can determine social validity in an indirect way and a direct way. So indirect would be very much the same as regular assessments, where it's interviews, questionnaires, rating scales. So you can give them forms and say like, how important is this goal to you? Do you feel like you are being heard? Things of that nature. Versus direct, which is normative comparisons. So like when kids take standardized tests, normative referenced. So normative comparison, I should say, is when you're compared to your peers. Normative referenced is more the standardized, like you're compared to more of a bell curve of a whole population. So naturally, if you're in a lower scoring area, then your scores should reflect that area versus like, oh no, you need to be at the top of like everything compared to everyone, right? So normative comparison is a bit more hyper-focused versus normative referenced is taking a larger population. They also discuss expert evaluations by just directly talking to the client and the caretaker, if that's possible, and kind of assessing social validity of outcomes from there. So that was Unit 2. I know it covers a lot, and each of the steps and the levels and the phases all have a lot of just minor subcategories to them. So when you're doing this particular unit, just make sure that you keep them all in order. The test does ask for most of them, as far as I recall. And this was not a difficult one. It was just a very tedious one, as far as like my cohorts and I discussed this particular unit. But it's because it's so subjective with the whole social validity aspect that it just feels like a lot. But it really isn't. They just break it down into terms we within ABA can understand. So hopefully it makes sense. If you have any questions, leave them down below, because there's a lot of content within this one. Yeah, I hope that helped, and I will see you guys in the next video.